Welcome to GHAPPcast, the official podcast of Gastroenterology and Hepatology advanced practice providers. I'm your host, Christina Hanson. Thank you for joining us for another insightful episode where we dive deep into the world of GI and hepatology. Today's episode, entitled Navigating IBS, Pathophysiology, Neuromodulators, and Patient-Centered Care, focuses on enhancing our ability to educate and discuss IBS-C with our members and our patients. Joining me today is another GAP member, Kim Kearns, a seasoned expert in the field. Welcome, Kim.
Thank you so much for having me today, Christina. It is an honor to be a part of the podcast and, of course, to present with you today.
Absolutely. So together we'll share the hurdles we've encountered in our practice related to understanding and managing constipation predominant irritable bowel syndrome. We're going to discuss the strategies to overcome these challenges and answer some of the most common questions we've received from patients. Questions that we've also gathered from you, our listeners. So whether you're on your commute, taking a break, or tuning in from your clinic, get ready to gain new insights and tools to help you have more meaningful and effective conversations with your patients about IBS-C. Kim, let's get started. Welcome to the show.
Can't wait, Christina. This is going to be so much fun.
Yeah, and I think one of the biggest, kind of hottest topics is this idea of disorder of the gut-brain interaction. We know this has kind of been a shift in thinking. We've historically called this functional GI disorders, but we now are titling it disorder of the gut-brain interaction. So I think it's well established that this is one of the main pathways of irritable bowel. So
yes.
How do you go about talking to your patients about gut-brain interaction or disorders therein?
Yes. And Christina, thank you so much, because I do think it's really important, even to our listeners, right? I mean, we've kind of had a shift in the way that we've actually talked about irritable bowel syndrome, right? So this disorder of gut-brain interaction is actually a recent term that kind of more encompasses actually dozens of disorders. So it, as you just mentioned, it like previously replaced what we called functional disorders, right? So to kind of give it a little bit more validity, right? So, and again, to clarify, this information that both Christina and I are chatting about here, this disorder of gut-brain interaction actually has been obtained by the Rome Foundation. So disorders of gut-brain interaction are classified by GI symptoms that are related to any of the combination of, which include motility disturbances, visceral hypersensitivity, altered mucosal and or immune function, altered gut microbiota, and of course, as you and I like to talk about this, altered central nervous system processing, right? So, and I think that this definition, and the reason I kind of wanted to pause and go back to that, because I think it wasn't until I really started to understand that, what does this disorder of gut-brain interaction actually encompass, right? So, and it's most consistent with, I think, what we're all understanding is this evolution of the multiple pathophysiological processes that either in part or altogether actually determine the symptoms, right? That, of course, characterize what we all know predominantly as the Rome criteria of irritable bowel syndrome, right? And I think we're all super familiar with, the definition of IBS, but then this goes back to, how do we actually explain this to our patient, as like that was kind of the beginning question. Forgive me for going backwards, but I think, it's a great part to kind of review what that actually looks like, those disorders of gut-brain interaction, right? So again, we mentioned the pathophysiology of IBS is actually multifaceted and very complex. So how do we explain this disorder of gut-brain interaction? I think you and I have had this conversation before, Christina, and I love the way that we chat about this. But I begin by really talking about this bimodal communication that exists between the brain and the gut, right? So this bimodal communication actually we know is stimulated by neurotransmitters like serotonin, right? And dopamine that is responsible via, our central nervous system. And again, the reason that I paused and talked about what the disorders of gut-brain interaction are is because we have to recognize that it has something to do with the altered right? Central nervous system processing, right? So pulling all of these things together, I think really kind of helps how we describe this gut-brain interaction for our patients, right? So as Christina, I remember that you and I had this conversation before, but these neurotransmitters like serotonin and dopamine responsible for this bimodal communication, right? But we know that sometimes when there's kind of a lack of communication or a disruption in that communication, it can result in changes in motility, secretion, and even immune function, subsequently leading to our classic symptoms of IBS that we have.
Yeah.
Now, I think when talking to patients, it's hard sometimes we talk about these neurotransmitters, but this is when I pause and say, hold on, I've got a little fun fact for you, right? Remember that the gut contains more than 90% of the body's serotonin and half of its dopamine, right? So when we talk about how this works together, this connection, I think then the pieces start to come together for the patient, right?
Yeah.
So I think you've said it best, this altered connection that between the brain and the gut then trigger some of these symptoms, like this overstimulation that usually the brain kind of dampers for us, right?
Yes.
So this then leads to that increase in some of this abdominal pain, visceral hypersensitivity that we see, and again, change in bowel habits. Christina, do you have any other ways that you kind of explain it to your patients?
Yeah, I think that's great. And I think one of the things that I always talk about, and we're going to get into the multifaceted or the multiple pathways that are contributing to the symptoms with this overarching of this disordered the communication between the brain and the gut. But, you know, your patient often comes in feeling invalidated. They don't feel confident in their diagnosis. We're going to get into talking about a patient-provider relationship and how to dispel some of the myths around IBS for our patients, so they do feel validated and confident in their diagnosis. But a lot of times they'll come in and they say, you know, there still must be something wrong, right? There must be something wrong. And, or they think it's all in their head. But one of the things that I think is beautiful to unravel for our patient is, guess what? There is something wrong. There are pathways contributing. And kind of at the head of that is this disorder between the brain and gut. The brain and the gut are in constant communication. And they're using nerves and they're using chemicals, as you said, with dopamine and serotonin. And the gut sends these frequent messages to the brain. About what's going on. Oh, I need to have a bowel movement, or I feel full from my meal. And we talk about it's more than just the gut, the intestine or the colon, right? The stomach, all these functional things. And the brain usually says, hey, chill out. It kind of dampens these signals to kind of minimize the discomfort and help tune the functioning of the gut. But when there's something that goes wrong, and there are many theories about some of the things that occur that may cause this disruption in the brain-gut communication. Maybe it's prolonged disturbances, stress, some kind of infection in the past, disordered sleep. You know, there are multiple theories of what could cause this disruption between the brain and the gut. And when the brain actually perceives these stimuli from the gut more strongly, that is where we get this inappropriate signaling. And then in turn, we get these disturbances in intestinal function. So disturbances in motility, and, the pain perception. So again, having that, hey, normally our brain kind of says, chill out, gut. When there's some disturbance, it is not able to regulate that same way. So for you as a patient with IBS, the natural signals for motility, food digestion, motility in the gut, you're feeling it 10 times more than a healthy control. So kind of trying to bring it back around to, yes, there is something going on, and it starts here. And then it leads into all these other types of multifaceted pathways that are working in concert or working against you to give the symptoms that we have with IBS. And I think that's kind of a good segue into this second part of this question. How do you talk to your patient about these different pathways? Because it's not just one thing going on. There are multiple things happening, giving symptoms that are related to IBS. So how do you go about moving further into that pathophysiology that you sort of started with, Kim?
Well, as we all know, right, the pathophysiology of IBS is so multifaceted. And I think that there's still an evolution about really us as, clinicians understanding what causes IBS. So, and I think just to take, Christina, you're completely right. When a patient comes in, we need to validate what they're feeling. And I think that part of this new definition of disorder of gut-brain interaction helps validate that. But how do we talk to them about how this happens? And I think some of the underlying pathological factors that lead into that, which again are evolving helping and we're understanding, right? We definitely know that stress, right, and depression, anxiety can definitely cause some of this kind of this, I would have to say, lack of communication or disruption of communication that can lead to a disorder of the gut-brain interaction. Also, immune activation. And whether, as Christina mentioned, could it been from an infection? Could it just be even from alteration in like lack of sleep, being overtired? We also know that alteration in the microbiome or dysbiosis is a key player, right, when it comes to the underlying pathophysiology of IBS. But even from this gut-brain, that we're looking at, this interaction, we know that some of these signals are even the, as we know, this barrier dysfunction can allow for them to be a signaling change, which again leads to the symptoms that we see with IBS, which again, this visceral hypersensitivity, abdominal pain symptoms, and even change in bowel activity. And again, all of these are proposed or kind of evolving kind of pathophysiological processes. And I think too, for a patient is actually kind of even telling them, like, we don't know exactly why this happens, but here are some of the proposed reasons that we feel why it can happen. And then as you start to kind of dive in a little bit more, I think that this is, Christina, where then like the layers begin to pull back, right? Yeah. The patient starts telling you a little bit more about, do they have social stressors? Do they have anxiety? Have they been suffering from depression that maybe they just haven't actually been, as said, to any other provider, right? Yeah. And I think that really helps by laying it all out. And before we go further, Christina, I'm going to head it back to you, but you had actually said in a previous lecture that you and I had done together that there's an amazingly great article that was published in Gastroenterology by Kiefer calling Explaining Brain-Gut Access to Patients. And I think that it's worth a mention because I know that I've read it before, and I think it really helps like us as providers explain this to our patients as well.
Yeah, absolutely. And again, we're going to get into talking about the importance of the patient-provider relationship, dispelling some of the myths around it. But one of the best things I think we can do for our patients to help them validate, to help them to be able to confidently claim their diagnosis, and to help them understand that there is something going on. So they're not constantly coming back and saying there must be something underneath, there must be something underlying, because we've had a shift in this whole idea of it's not a diagnosis of exclusion. It's this positive diagnostic strategy, meeting Rome criteria, absence of alarm symptoms, long-standing abdominal pain associated with change in bowel pattern and consistency of stool, occurring with defecation, that we can be confident that this is a diagnosis and there are multiple things happening at the level of the gut and the brain. Disorder in motility, we've got in the setting of constipation, a decrease in colonic contractions, water imbalances leading to these harder, less frequent stools. We've got issues with increased intestinal permeability, so those tight junctions that we're supposed to have. We get increases in that, allowing for more bacteria and toxins to get through to the submucosa, causing these inflammatory reactions next to these nerve fibers. So that's where we get the visceral hypersensitivity. So I'd like to give them that big word, right? Our patients love to hear, hey, this is the pain that you're experiencing. It's called visceral hypersensitivity, right? And they like that big word, and they can go around to their friends and say, oh, my visceral hypersensitivity is acting up, and they can claim that. And you can validate them and say, that's one of the pathways occurring, leading to the pain that you get. Hey, guess what? This is the pain that leads my patients in and out of the ER. So be validated. You're right. Microbiome. There's dysbiosis and other types of immune activation. And patients are really bought into the gut microbiome, right? They're all brewing their own kombucha out here in Colorado. They like to come in and talk about gut microbiome. And you can give that to them. We think there's a degree of dysbiosis occurring. So I think it really helps to have a nice, educated period of talking about pathophysiology with our patients so they can understand there's a heck of a lot of things going on all at the same time. I'm not just making this up in my head. This isn't just a bucket of diagnosis of exclusion. And guess what? There are a lot of different tools in the toolbox that we can use to help with these different pathways. It's not a one size fits all, but we've got a lot of resources. So helping them to understand the pathophysiology and how complex it is, but at the same time that we have options out there for management, I think is super, super empowering to our patients.
100%. And I think wow. So much.
Talking about management, one of the things that we have available to us is this idea of neuromodulation. We've got these ability to use neuromodulation for some of the different symptoms that we have with our patients with IBS. Kim, when do you reach for a neuromodulator? And what does that look like in your practice? How do you talk to your patients about that?
Yeah. So I think that this all lends back to how we started this conversation, right? We're talking about a disorder of the gut-brain interaction. We talked about the neurotransmitters are involved, right? So this should lead us as clinicians, okay, let's choose a therapy then that would be a neuromodulator, right? That seems to make sense, Christina, right? That's why we're kind of going through these steps. And I think it's also important that we talk about it this way to our patients, because when we utilize neuromodulators, we have to remember, right, that we're using a tricyclic antidepressant most of the time or an SSRI, so selective serotonin reuptake inhibitor. And patients, I think, get a little bit, what do you mean you're going to give me an antidepressant? What do you mean you're going to give me this type of therapy? So I think it helps by laying the foundation first, that Christina and I started with, talking about why, right? Then utilizing neuromodulators and where do I grab them in practice? Christina, I love that you just asked this question, by the way. This is my favorite therapy to use for patients who I truthfully believe have more of a visceral hypersensitivity or, helping with visceral pain and needing that more of that smooth muscle relaxation. So, and I'll tell you, even when we look at some of our guidelines that we have, when we look at the paradigms of what we move through when choosing therapies for our patients with IBS, I think neuromodulators, are not first line. I'll tell you that, Christine, I'm sure you can agree with that. We don't use them first line, but for patients who have persistent pain that we can definitely recognize as likely related to visceral hypersensitivity, pulling back those layers that we talked about as to the why, and then saying, okay, now let's add in, and sometimes I use it as an adjunct therapy, let's add in, one of our neuromodulators. So there are a few therapeutic classes that we can address. So Christine, if okay with you, I think that we can start with the tricyclic antidepressants. That one's, of course, been the most studied, I think, in IBS as well. So with our TCA group, of course, we have amitriptyline, nortriptyline, and I think Christina and I can both agree, start low, go slow with that one. Always. And usually if you are going to use it, again, we recommend, using it in the evening time. So we usually start with a dose of 10 milligrams, usually and taken in the evening. And now remember, the TCA, and I want to explain, this is a serotonin and norepinephrine reuptake inhibitor. So it has both cholinergic and histamine 1 antagonists, right? So what does this mean? So it can alter GI transit, so kind of slows things down a bit, just as Christina and I were talking about, how it can alter motility, and of course, decreases visceral hypersensitivity. So helps with that pain component to it. But again, I think with that reach, as you would like to say, we always have to remember that I think that this therapy, so TCA, is preferred in patients with persistent, moderate to severe abdominal pain. And I think the caveat here, Christina, which I'm sure you can agree with, is patients who have more loose stools, right? This is not a therapy that I would potentially use for someone who's constipated, unless I'm throwing an adjunct on there as well, because we do know that one of the number one things that we see with the utilization of the TCAs is, of course, constipation. Christina, I think we did a lecture together on, the guidelines and how they're actually being used. And we know guidelines are just that, they're guidelines. But just to provide, I think, our listeners with some information, the 2020 ACG guidelines actually gave TCAs as strong recommendations for utilization for IBS, looking at the global improvement of IBS symptoms. And for patients with IBS, of course, the AGA suggested using TCAs as well. They gave it a conditional recommendation. So even our society guidelines, right, are suggesting the utilization of TCAs. Christine, do you want to add anything else about TCAs before we jump into another class?
Yeah, I think that's perfect. They're the most rigorously studied, as we've talked about. Really want to use it for that pain component with those patients that maybe have a looser stool because of the potential side effect of constipation. And I think, just to your point, our patients will often, and we kind of dovetail or caveat or tee up the conversation. Yes, these are antidepressants, but we recognize that TCAs and other antidepressants have this physiologic effect that's separate from the effect on mood. These agents really have been now relabeled as agents that we can use in gut-brain neuromodulation. So having that conversation with that, we do have a lot of patients that, maybe meet criteria for management of depression or anxiety. And you'll talk about SSRIs in that pocket of population. So there could be an added benefit. And maybe some of these patients are on different agents that we can work with their psychiatrist or their counselor or their primary care about how could we maximize this and, get more bang for the buck on something that could help with both their depression and anxiety, but also have an added benefit when it comes to their IBS. But, having that, dispelling again, that myth or that misunderstanding that actually there's physiologic benefits that these can provide, that it's actually separate from mood, but we could also maximize that. And there are more than just the TCA. So Kim, I'll let you to speak a little bit to the SSRIs.
Sure. I think, SSRIs as well. So our selective serotonin reuptake inhibitor, right? So again, potentially a more favorable side effect than our, TCAs. And again, what we see with our SSRIs specifically, and again, as Christina mentioned, this is why we talk about the beginning of that disorder of gut-brain interaction. We talk about where the serotonin lives in the GI tract. We talk about these neuromodulators, that we're specifically talking about therapies, right, that are working on, of course, these neurotransmitters that we are talking about actually, are super involved when it comes to the underlying reasons for these, disorders of gut-brain interaction. So starting off by explaining why, then of course moving into the therapies that work specifically on some of these neurotransmitters, right? Now it all kind of makes sense. Even the patients are like, oh, okay, I get it, right? There becomes a little bit more of a buy-in, right, Christina? So the SSRIs, right, again, with those, there's an increase in small bowel and, of course, sometimes colonic transit time with the SSRIs. And again, for those, we use citalopram and again, sometimes escitalopram as well. And again, start low, go slow, as we always say. And just from a guideline perspective, just so everyone knows, the ACG, the 2020, ACG guidelines did not actually give a recommendation. And unfortunately, for the AGA guidelines, they actually suggested against using SSRIs. It was a conditional recommendation, but, some of our society guidelines don't suggest the utilization. And I think that has to maybe, as Christina and I talked about in the past, what we were looking for in those guidelines, looking at global improvement, but do we still use them? And I think Christina and I can both agree to, yes, we do use these in practice, probably as an adjunct therapy, maybe not as often. I would probably say I reach for a TCA a little bit more often, but again, in specifically a patient population that we talked about before. And again, this is more for my patients who are experiencing pain, 100%, pain. And then even as Christina alluded to, a little bit of that, depression or anxiety component as well.
Yeah, definitely. And again, in a different lecture or different podcast, we talk about, the FDA approved prescription therapy that we use in constipation, predominant irritable bowel, and then how we use neuromodulation. And then when we go, there are other, non-pharmacologic options that we can consider as adjunct, as you said, when our patients are still having persistent symptoms despite these other interventions. And in particular, this idea of gut-directed cognitive behavioral therapy. So how do we best utilize cognitive behavioral therapy? When is it the right time to intervene? And what's the right patient that we should be looking at to consider this for, Kim?
Yeah. And Christina, I think that this has definitely changed even in how I utilize it in practice. And we can talk about why in just a few minutes, because I think that you and I come from, being nurse practitioners for a long time. But again, there's actually really strong support and clinical evidence and, of course, even professional guidelines in the utilization of cognitive behavioral therapy as adjunct to treatments in IBS, right? So this shouldn't be monotherapy. It should be adjunct therapy. And just as a reminder for those of us in the audience, right? And this is what I also talk to my patients about. When we're talking about cognitive behavioral therapy, we're really focusing on negative and disruptive thoughts, feelings, and behaviors that then lead into manifesting into GI symptoms. So specifically for cognitive behavioral therapy, this should be, considered for patients who probably have, more significant physical and psychological distressors, right? What I like to envision this is, patients, of course, for those that have, would, I think, benefit most from cognitive behavioral therapy. And then they have these symptoms, right? And then this is how I explain to them. They're cramping or they're getting pain, right? This is their symptom, right? And then their cognition is, oh no, I'm going to have a bowel movement, or what if I have an accident, or, this pain is so unbearable, right? So then they start to have an emotional response, fear, anxiety, shame, isolation, right? And then they have a behavior, of course, that then doesn't allow them to eat, right? That doesn't allow them to go to work. That is super disruptive to their activity of daily living. So that's the kind of, cycle, when I'm hearing a patient explain it to me, this is the type of patient that I think, okay, this patient would probably benefit from cognitive behavioral therapy. right? And from cognitive behavioral therapy, right? We have cognitive behavioral therapy. We also have a few other types of therapies that are non-pharmacologic, right? And another one, of course, is gut-directed hypnotherapy. And forgive me for jumping right into that, Christina. But again, these would be also considered for like refractory patients.
Yes.
And it's effective for patients that have IBS. There is data that suggests utilization of gut-directed hypnotherapy. And for gut-directed hypnotherapy, this would be someone who's got, the somatization of, extraintestinal symptoms, right? So that they continue to have symptoms, or they're having pain, catastrophizing, or fear of symptoms, right? These are also kind of the same patients that we know. So I think that gut-directed hypnotherapy and this cognitive behavioral therapy patient, probably there's a bit of overlap that kind of definitely leads into that as well.
Yeah, absolutely. And I think you're right. I think adjunct, for that treatment refractory, and honestly, probably something that is underutilized. I would say even in my own practice. And there's a lot of resources online of, areas where you can find these type of therapies in your region and in your city. So I think it's something that we need to think about more often, especially, again, for those patients that have these, negative and disruptive thoughts and feelings and behaviors. This is a perfect candidate that are treatment refractory that we probably need to, again, think about moving towards this more often. And so, again, resources online for your region and your area for you to go for, because I think, again, it's something even I need to, think about more often. Can be very successful for our patients, for sure. Absolutely.
100%. And especially that overlap. And even, the AGA, they have their guidelines and even their clinical decision tool, utilizing in their clinical decision tool, they have patients who are refractory to, already going through your therapeutics, right? Yeah. To add in, gut-directed, hypnotherapy and even cognitive behavioral therapy. And as Christina mentioned too, I think some of the things that I kind of alluded to is this whole shift again in digital therapeutics for IBS, right? So these were the things that we didn't have when you and I first started practice. We didn't have these things. So now there are multiple opportunities for digital therapeutics. So back in the day when we would potentially we couldn't even consider giving the recommendation because we didn't have a provider who could offer it.
Right.
Now there are multiple digital therapeutics for IBS that come in app form, that come, that also have, the digital platforms. So you could do Zoom meetings. So, the provider could be in a completely different state, but also just so much more access. So Christina, I completely agree with you. This is something that I've reached to much more in clinical practice. I would think over the last 2 years of my career, knowing that there is access in seeing the outcomes, right? These positive outcomes for these IBS patients when they add in, specifically the cognitive behavioral therapy that comes from these digital therapeutics that we have for IBS specifically.
Absolutely. Yeah. And I think many of our patients, and, we tend to see IBS in younger individuals, and they're more hip, right? They like that virtual platform, the digital options. And I think that's part of, having a really good patient-provider relationship and that idea of this shared decision-making, understanding what our patient's going to respond to, what their learning platforms are, what they're going to get out of most, and obviously understanding that and it helps to, again, empower our patients. But we have to ask those questions. So that kind of leads into understanding what is this whole idea of patient-provider relationship and shared decision-making. It seems like a buzzword, but we understand that a positive patient-provider relationship really maximizes a patient's journey and their response. It helps them to feel empowered. It helps them to self-manage, improves patient satisfaction. How, Kim, do you go about this with your patient? What does this mean to you, this idea of shared decision-making with your patient?
Yeah, absolutely, Christina. And I think like the key point here is that the patient-provider relationship matters, right? It really matters. This just isn't someone who's like a time slot on your clinic, right? Yeah. This has to be something that matters because their health journey, you're a part of that health journey. And so you're a part of that journey and you're a part of that relationship. And as Christina alluded to, strong patient-provider relationships are essential, right? We have to understand, their subjective experiences of IBS-C right? And consequently, this then helps us as providers achieve accurate symptom reporting, right? We know that then they're going to tell us exactly what's going on. That's step number one, right? That's how we get to, what we need from a subjective perspective. But also this positive relationship, right, that we have empowers patients to self-manage, enhances treatment compliance, right? Increases satisfaction, as you mentioned, improves health outcomes, and decreases additional healthcare visits, which this in itself, we recognize on this journey that patients have for IBS is exactly what they need to get their life back, right? To get their life back altogether. So, and I just want to focus that, that shared decision-making. I think that was a buzzword in some of our other kind of chronic illnesses that we had, right? And now really moving into almost every kind of, I would say, domain of GI that we have. And just remember, shared decision-making is a collaborative process, right? Yes. Patients and providers work together. This is what I tell the patient. I'm like, we are in this together. Yeah. This is your healthcare journey, but I'm here to help you make an informed decision, right? So we share information, we get everything together, and we consider, though, the patient's values that go along with it. And of course, what is their preference, right? We always have to make sure that they're included in the decision. And then ultimately, collectively, the shared decision-making process, you collectively come together regarding a decision on their management of a patient, right, that you both agree upon, right? So, and I think that there's lots of elements of shared decision-making, which, we could have a whole lecture just on shared decision-making, to be honest with you, Christina, right? So we've got information sharing, deliberation, that decision-making, and then that implementation process of it. And I think that those are the things we have to consider when doing this shared decision-making. And I think just some key points, right, for those of us for shared decision-making. How do we ensure that happens in our visit, right? Ask open-ended questions, right, Christina? I think you and I, we could do that to each other all day. But listen actively, give signs that you're listening, understand the patient's perspective. This is all about that collaborative process. Make sure that you're sharing information back and forth. Recognize that this is an individualized treatment plan. And I tell all of my patients, everybody gets a different recipe. This is your recipe, right? Like on your healthcare journey, this is your recipe. Here's your individualized plan. But part of this too, in this shared decision-making, is making sure that you reach an agreement and then summarize what that looks like. I always make sure when I'm done at the end of the visit, here, this is what we talked about today. And then this is how we're going to follow up on that, right?
Yep.
Christina, I know that was a lot. I apologize.
No, you're spot on. And it kind of leads into talking, and I would probably marry these last 2 points, the importance of patient education, because one of the things that I think will make a successful patient-provider relationship with shared decision-making is really educating that patient and dispelling some of those myths around. Remember, these are patients that have bopped around for years to different providers. They maybe haven't been given a confident diagnosis of IBS in the past. Like we talked about, it's just this bucket of diagnosis of exclusion. They don't feel confident in their diagnosis, certainly don't feel empowered. They continue to feel like there must be something else going wrong or, underlying. So being able to have that very first visit where you have that diagnosis of IBS, giving them that validation. One of the things that I say to my patients is, hey, IBS, while it's not going to affect your lifespan, it's definitely going to affect your quality of life. And unfortunately, we can't get rid of it. This is not something I'm going to be able to cure completely. But the goal is to get you to as much quality of life as possible. And it's very subjective, right? It's very much based on what is response to you and what's adequate response. There's a difference, right? And my goal is to get you to as much quality and adequate response as possible. But there's periods where your IBS is going to flare up or act up, and there's times where it's going to be a little bit more smooth. But we're going to walk this, as you said earlier, Kim, we're going to walk this together. And as much information and feedback as you can give to me will help me to be able to care for you as best I can. There's a lot of things in the toolbox, but it's going to be very subjective to that patient. And it's a hard thing for our patients to talk about, right? Talking about your bowels, it's not an easy thing. So making it a safe environment for that patient to be able to talk about, telling that patient, hey, the more, details you give is going to be better. So just lay it on me. This is what I do. So being warm, having a smile, open-ended, eye contact. I mean, we get a few patients, right, that are very comfortable. On their phone, they've got the weekly constitutions and pictures for us to go through, and so they're it's like the Bristol stool scale right on their phone there in picture form. So you get a few that are very comfortable, but otherwise it's not an easy thing to talk about. No. So being warm, being inviting, being open-ended, telling them that the more details, the better, that it's very much what they're feeling, and allow them to feel validated and empowered, and be able to feel comfortable talking about it. And knowing that we're going to align our goals as much as possible from me as the provider to you as the patient. And what you're feeling trumps everything, right? If you have abdominal pain right now, that's a 9 out of 10 scale, with 10 being you should be flat on your back, and at least you should be army crawling towards me as a 9 out of 10. And if that's what it is, be validated. I'm going to try to get that feeling better. So I think you're right. I think it's something where you need to have good education around what IBS is, help your patient feel validated around that, help them to know that you're in it together. And hey, this is going to be something we're going to walk together, throughout your journey. And there's times where it's better, times where it's not, times where it's worse. And, certainly we're going to be there, as partners really, in this and help them feel validated. And there's a lot of different ways that we can go about educating our patients around IBS. There's a lot of different resources. I think it's, again, really important to understand how your patient is best learns, how they can be best educated, and kind of maximizing that. Are there any kind of best practices around how you go about educating your patients around IBS and management therein, Kim?
Yeah, sure, Christina. And I think you hit it right on the head. And I think, just to quickly summarize, when it comes to education regarding the management of, disorders of gut-brain interaction, it includes first building that therapeutic relationship with which we talked about, explaining the diagnosis clearly, name what they have, validate their symptoms. And then I think, as Christina and I both said, we're talking about this journey and, kind of being with them, but also it's about setting expectations, right? About setting expectations of, what will happen when we use these therapies, what will happen when we add on cognitive behavioral therapy, what will happen if we add on a digital therapeutic to kind of help with that as well. But as Christina said, how do we then, and parting of this journey, right, is also just this education, right? Explaining everything. So I think, there are definitely tips for providing, effective education for patients with irritable bowel syndrome. And as Christina, you hit it right in the head, individualized learning for your patient and understand what their interest is. A lot of these patients are young, they're way hipper than us, right? Yeah. But again, for them, maybe it's a digital therapeutic, right? Yeah. There's lots of digital tools that can help with that. Are they better off, like looking at, possibly a flyer? Do they need something more of a podcast, right? So really individualize their learning to stimulate their interest in what they're looking for when it comes to management of their IBS. There may be some patients who don't want this, by the way. Yeah. So I always kind of, test the waters. What's the temperature of the room, right? What are they actually looking for, right? But also you have to consider the patient's limitations and strengths when we're considering effective education, right? If it's someone who's a little bit more, I don't ever like to use the word old, right? So elder, right? If they're elder, is a digital therapeutic option for them? Unlikely, right? Yeah. So think about their limitations and strengths. Again, do take advantage of technology if appropriate. And when we're giving education, include members of the patient's either community or family to give them support, because this is a lot, for some of these patients, as Christina mentioned, they've been going from doctor to doctor to doctor 5 years, this journey of not feeling well. Finally, we give them some validation. Yeah. And again, give them a diagnosis, but this is sometimes a lot to absorb when it comes to this journey of IBS with them. So provide community support as well, I think is one of the biggest things that I recommend too.
Yeah, absolutely. Absolutely. And I think, again, just to kind of, summarize too, and this idea around this isn't something we're going to cure, right? Helping them to understand kind of the long-term journey we're going to be on. I think it sometimes takes a few visits, bringing them back. And some of our IBS patients, they are on our doorstep every other week, and that's okay, because I think there's a lot of dispelling the myths, as we talked about early on, and giving them a confidence in their diagnosis. And it may take a few visits and a lot of good reassurance around their diagnosis that while we're not going to be able to get rid of it completely, there are a lot of different things that we can make you feel better with and have as much quality around your diagnosis with, and really, again, empowering them. So again, bringing them back, continuing that education, having those conversations each time, and really, I think providing a lot of reassurance is really, really key to the success that we can get with these patients with IBS. So I know, Kim, we could talk for hours on this subject, and we certainly have. And I really, really appreciate, as we kind of wrap up today's episode, want to thank you for being a part of this and joining us today and honestly sharing such valuable insights. You are just, a whip smart individual, and you've been practicing for so long, and I could just go to you on a whim and say, Kim, advise me on this. So it was fantastic having you here. Thanks for being a part of it.
Christina, thank you. It's always a pleasure discussing these important topics with you and, of course, our listeners. I hope that we've provided some useful strategies and answers that can empower our fellow GI and hepatology APPs in their patient conversations. And Christina, I couldn't agree more. There isn't anyone I would rather do a podcast with or share information on, and I, too, am honored to be a part of this with you today.
Absolutely. And thank you, our listeners, for tuning in from wherever you're coming in today and for submitting your questions. We hope this episode helps you feel more equipped and confident in discussing IBS with constipation with your patients. Remember, you're not just providing care, you're educating, which is a vital part of our role. Make sure to subscribe to GHAPPcast on your favorite podcast platform to stay updated with our latest episodes. And don't forget to explore the growing GAP ecosystem further. Visit our informative website at gap.org and connect with us on Twitter at GastroHepAPP and Instagram at GastroHepAPP for the latest updates, insightful content, and exciting announcements. Until next time, this is Christina signing off.